Good morning, everyone, and welcome to our Spokane County Regional Interlocal Leadership Structure Meeting, SCRILS. We won't be having our chair of the Spokane County Board of County Commissioners joining us today. Unfortunately, she is out, so you'll have to just deal with me today. So my apologies if you're expecting the wonderful and lovely Mary Cooney, but unfortunately she can't join us. So moving forward, it looks like we have a lot of people joining. For our meeting, we normally have everyone enter in their name, organization, and title in the chat so we can keep track of attendance and mark that. However, I do believe we have some new faces, so I'm going to also open this up and say, is there anyone that would like to introduce themselves if they're new? And then we'll give a little background on the SCRILS, what we hope to accomplish. And I'm looking at Ponderay.
That's correct. Hi, my name is Shannon Hollefeld. I'm the new Director of Counseling for Ponderay County Counseling. Happy to be here and learn more about what we're doing here at this meeting. I did look you up on the internet, so I could get a little snapshot, but coming here with open ears.
Excellent. Welcome, congratulations. And
Thank you.
we're gonna need to touch base. So
Excellent.
looking forward to more conversation. All right. And just a quick shout out to the new CEO of Frontier Behavioral Health. Congratulations, Kelly Miller.
Thank you, Justin. It starts tomorrow, though.
Well, I got to jump on it. So, congratulations.
Thank you, Justin.
Yes. All right. So we've got people joining us. Please, as we've discussed, put your name and information in the chat. We'll keep track of the information for attendance purposes there. Is there anyone else who is relatively new that would like to introduce themselves to the group that we haven't heard previously? No? All right. We will jump right in. Good morning, everyone. My name is Justin Johnson. I'm the Director of Spokane County's Community Services Department, and the SCRILS meeting, the Spokane County Regional Interlocal Leadership Structure meeting, is something that was put in statute back when there was a transition from bifurcated system into integrated health with behavioral health and medical services with the current system. So it's been 6 years now. As part of that, the hope was to help transition that into a cohesive and comprehensive system, conversations, and local communities give feedback and allow for that transition to occur. When that statute expired in 2021, I believe, our region decided to continue that structure because we like the conversation and the engagement, and we also like that ability to be able to have a direct conversation, not only with all of our regional leaders, our commissioners and elected officials from our 6 counties, as well as state representatives in the governor's office. We felt that was absolutely critical to keeping the conversation of service delivery and network adequacy, as well as ensuring that our managed care organizations and our community stakeholders are all on board. So that is what this meeting is intended to have, a high-level conversation as well as solution-focused look at how do we address challenges in the region and how do we voice those at a statewide level to be able to have direct engagement to address challenges that we may be facing and or to highlight wonderful and new emerging solutions that may be community-based, regionally based, or even statewide. So that's the background intent of this meeting. We do have standing topics and opportunities for individuals, but as always, if any of the members that we have sent this out would like to share, please feel free to add agenda topics at our quarterly updates. So I'm going to pause there, see if there's any questions before I move into our agenda topics. Hearing none and giving the obligatory 3 and 33-second pause, I'm going to transition to our first agenda topic. So we usually give this opportunity for the Healthcare Authority as well as other state entities to be able to give an update. So I'm going to open this up. I know we have for one of the topics, legislative updates. I know we're a little soon out on this, so this isn't a requirement, but we just want to make sure that it's there as a carryover, and any other topics that HCA would like to share. So without further ado, turning it over to Jason and team for any updates you might have.
Hey, good morning, all. Thanks, Justin. And I'm on my phone. My computer is not cooperating very well this morning, so I'm trying to reboot. I know Jessica's on from HCA, Jessica Diaz. Thank you, Jess. I'm not sure I see anybody else on from HCA. So let me just double check. Anybody else from HCA on this morning?
The behavioral health conference is going on right now, so our
right.
HR partners are attending that conference.
Right. So it's just us today, Justin. Jess, I was going to just update about some of our reentry related work, and maybe I can touch on some of our children and youth behavioral health work, if of interest. Jess, anything you were planning to cover today? And Justin, of course, if there's anything specific you and the commissioners or others would like to discuss, happy to stand for questions.
Excellent. Well, if you want to kick it off, we'll let the members, if you have any topics you'd like to have HCA touch on after they give an update, please put it in the chat and we'll make sure to call out that agenda topic to them after they get done with updates on. I'd love to hear about reentry. Jason, that sounds like it's something we're very forward thinking in Spokane and have already put forward as part of our carceral cohort 1. So love to hear what the work you guys are doing on that end.
Great. And I think the computer's working. Can you hear me all right? Am I coming through?
Yep.
Great. All right. Well, that's always fun. The computer's never done that before. It gave me a very loud noise and error warning and rebooted all on its own. So hopefully that won't happen again. Well, again, good morning, everybody. Yeah, reentry, you mentioned it there, Justin. Cohort 1 is our initial stage of this work. And maybe I could take a step back. I don't presume everybody's fully knowledgeable about the program. So maybe a brief overview of that might be helpful. This is giving the federal government giving the state a waiver for the first time to be able to pay for Medicaid services 90 days prior to release from a carceral setting. That includes juvenile, it includes a state prison, includes local jail and local juvenile detention. So that has presented the major opportunity here, and quite frankly, incredible transformation and implementation challenge. We have set a goal for July 2025 for what Justin intimated as our first cohort of local jails, state prisons that may be ready to implement. There are choices about what the facility may be ready to implement. The mandatory set of services include case management, which many of our managed care plans already do to some extent. Many of our carceral facilities already have good staff that coordinate with community level services. We will have some additional sort of specific requirements related to the clinical care coordination that's necessary. So that's the first mandatory set of service. The second, and quite frankly, the most important in our view, is ensuring medication for opioid use disorder is available. That also includes alcohol use disorder, as medication is available for alcohol as well. But the mandate is just we must ensure at least that medication is available. Includes also ensuring understanding if somebody's already on medication that they continue it while in that 90-day prior to release period. And so for local jails, that basically means for the entire period, because the vast majority of the average is under that 90-day period. And I think that's going to be the most critical piece. The third mandatory set of services is, this is perhaps even the toughest one, is ensuring upon release that any medication, not just MOUD, medication for opioid use disorder, but any medication is in hand. So that would require really partnership with a pharmacy to ensure that upon release. And then, so if that set of mandatory services can be met by the facility, then starting July 1, we can start paying for those services. We can also pay for a set of what I'll just call sort of non-mandatory secondary set of services, which includes the full pharmacy benefit. Again, not just for MOUD, not just for 30 days upon release, but the full pharmacy benefit within that 90-day prior to release period, which that can include things like very expensive medication for hepatitis C, which is another critical element. So in my view, if we can improve MOUD and improve hepatitis C treatment, induction treatment, that alone is a huge success for us. And incredibly expensive medication on both fronts, especially the newer medication for opioid use disorder, the Sublocade and the injections, which are pretty critical because of the fentanyl intensity and the toxicity. So we really do need that level of treatment. In addition, the full sort of behavioral health scope of benefit is available, and even primary care evaluation, treatment to targeted treatment can be available. So it is actually quite a broad set of services: lab and radiology, durable medical equipment upon release, sort of all of that is available. We are working on the details now that will show the scope and specificity of the full benefit. So again, you got a mandatory set, you got a secondary set of benefit. You must fulfill the needs and readiness for mandatory for July 1, 25. And we have some flexibility to phase in that secondary set of services within a 2-year window after that. But of course, the full pharmacy benefit particularly, and I'd say the full behavioral health benefit, really incentivizes us to try to get ready for that benefit as soon as possible too. So that's the benefit, that's the waiver, that's the opportunity at hand. Let me pause on that. And usually, I think we've talked about that before, but just in case there's any questions, it's, this is one of those where I found it helpful to actually repeat it a few times before you really understand what we're doing here. It's not not easy to grasp all the details.
Yeah, Jason, I've got one question I know that we received. So a lot of the conversations around the facility receiving the funds to support discharge within that 90-day period for the expanded service you just talked about, does that also cover external providers in the community coming into the facility to provide treatment?
Yes, it does. And of course, it will depend on the specific level of treatment, the readiness review, and what you're authorized to treat. Again, the mandatory set versus the secondary set. If you're ready for the secondary set, then yes, a community provider, say a behavioral health agency, in the community could come in and do some E&M coding, behavioral health related treatment. If you're not ready for that in terms of a readiness review that confirms your full set of benefits, such as pharmacy, and maybe it's just MOUD, then there needs to be readiness, and then maybe that's something that your facility would be ready for, say, the next cohort, the next 6-month review period. So we intend to do this sort of look every 6 months, again, starting July 1, 25, to give a chance for phasing the full set of services in. And in fact, the federal policy really highlights, and I would say emphasizes, the preference for using community provider, because the goal of this is the transition to those community provider treatment upon release. So yes, Justin, absolutely, the community provider will be paid for. By the way, HRSA, the federal government agency who really regulates payment policy and coverage policy for community health clinics, has an open rulemaking now for our community health clinic offering in jail to that question, and whether or not that would be as part of its scope of coverage and part of its payment. For example, the new rules, I hope it's an error, but we have commented and really emphasizing that it should be for the full pre-adjudication and post-adjudication, that 90 days prior release. The draft rules would only cover post-adjudication. So like prison, like Department of Corrections, of course, there are post-adjudication in your local jails as well, but far fewer than pre-adjudication. So we don't think that makes any sense, and we have commented to HRSA on those rules, and I believe the Community Health Clinic Organization has as well, and then the national organization is doing that too. So just flagging that for you, Justin, I think relevant to your question there. Any other questions on the sort of scope of practice here, the coverage?
And yeah, we have one more question, Jason, and I appreciate the feedback on that. If a community provider was to provide a service as part of that post-discharge, how would they be paid? Is that through the grant directly to the carceral facility, or through the individual's covered Medicaid benefit?
Through the benefit.
MCO? So it would be paid directly through the contract that they would have with the MCO?
Yes. Now, we have a fee-for-service population as well, Justin, so maybe 10-15% of their population, chiefly American Indian, Alaska Native population is a choice. And some of our dually eligible population, our Medicare over 60, age 65 population with disability and low income that we supplement coverage for through Medicaid. Those are the two populations chiefly making up our fee-for-service population today. So we will need a fee-for-service option. And so in addition to payment through the managed care plans, we will have a fee-for-service option. And to make this easier on jails to bill for these services, including the managed care services, we intend to, and we have a RFI, request for information, out on the streets now for what we're calling a third-party administrator, a biller, an entity who could help jails with some of these services, care management, maybe the network service. Perhaps they're not the actual servicing provider, but they're an entity that can work with, say, a pharmacy, so the pharmacy can be the servicing provider for the jail. But certainly for the billing pieces, you may have heard of sort of a clearinghouse for billing. Many providers use a third-party clearinghouse today to do the billing. So we are thinking about hiring a third-party entity to work as an intermediary between the managed care plans and our fee-for-service provider one state-operated payment today to make it easier on jails so they don't have to necessarily do 6 different payment methods.
Excellent.
So that's on the streets now, and we're looking for entities who can do this work. Obviously, this is going to be the first in nation approach at this work, so we'll see what we can get, and we may not get it all, and it may be an evolution, but we'll see what we can do. Justin, you highlighted the cohort 1 application out there on the street. I think this is your question too with regard to the grants. So as part of the waiver, the feds have given us some support dollars that we have now made available, or will soon, based on an initial application or interest to participate that Spokane has, for example, submitted their interest to participate for cohort 1 for July 1, 25. And as part of that, we will provide a grant to help the local facility to prepare for July 1, 25 billing, to prepare for its readiness review, to prepare for staffing up or hiring, contracting with local providers, pharmacies, care management, working with all of that. So that is the grant, Justin, I think maybe you were just referring to. It is not for services per se, it is to prepare for the July 1, and then services after that would be billed. I would also mention another project that we are working on involves our healthcare management system. Basically our electronic health record. And it won't necessarily fit with our timeline for July 1, but it should be available, we are hoping, early 2026, and setting up with say a jail needs an EHR. And let me just back up and be clear. Really, for success here, we think the facilities actually need an EHR, an electronic health record. So you know what information, what the health record is of the individual coming in, and that the jail facility can share the information back out to the community provider in an effective manner. And really the only effective way to do that today more systematically is through an EHR. So the state has for some years worked on an EHR option as an EHR as a service, where the state holds the contract and the state loans a license out chiefly to smaller providers, smaller behavioral health providers, jails, great example. Others, say community organizations who may not be traditional healthcare providers and cannot invest or be expected to invest in an EHR. The state will have that as an option. So we are well on our way there. We have federal approval to offer this service. So that is a part of our readiness review. Again, it won't be available to actually be used, turn on July 1, but starting that period, facilities can start to work with our team. If you need an EHR, some jails already do actually have an EHR. But if you don't, or if you need a new one, this would be a great opportunity to get going. And then we're hopeful early 26 that will be up and running. So we may have a bit of a gap period of figuring out how to communicate the clinical information before that, but we think we can have some flexibilities to do that. So that's EHR. That's in preparation for July as well in terms of the grant dollars. The readiness review will occur And then hopeful success of that readiness review, we can sort of turn on this work July 1, 25. Any other questions on reentry generally, or anything along those lines? I might mention juvenile for a moment. It's an interesting distinction in the sense that federal law now requires it across the nation starting January, but yet we're still waiting for details from the federal government about that. And so it does not seem that it would be reasonable to expect a January 25 implementation for juvenile. The fact is, though, it is really just for post-adjudication starting January 25. So it is a smaller population than the entire population pre and post-adjudication. And the mandate is just for the care coordination piece 30 days prior. So maybe we can stand up some manual work starting January. But our hope is that we could combine this with our waiver work starting July, and that's a request into the federal government about compliance with juvenile. And I think the only other bit I'd say is that the juvenile detention system is different than usually most local jails. Usually juveniles run by the courts, whereas jails run by the county, and sometimes run by county public health versus county sheriff, police. So there's some differences in terms of authorizing environments across the state. So that has been a challenge, yet we're now, I think, well connected on all fronts here, working as needed with the right groups. Juvenile's just not been something we've developed as many systems as we have on the adult side. For example, we have our jail booking reporting system through our Washington State Association of Sheriff and Police Chiefs. You may have heard of the JBERS system, the jail booking reporting system. That actually tells us where people are, where they're booked. And so we don't have that for the juvenile side today. So we may need to be building out some of that system as well. I think we covered quite a bit there, probably more than you wanted me to, Justin, but
No,
okay.
It was very informative. I actually very much appreciate that, because as we look towards being in that first cohort, that's all questions that I was going to have for them anyways. So very much appreciate it. We're not seeing any questions in the chat and no raised hands.
Great. Well, and I might just note quickly too, something that I think is incredibly important, and perhaps maybe some of our most critical work for health promotion prevention, is our children and youth behavioral health work. I have the really honor and privilege of being our co-chair for our legislative executive committee on children and youth behavioral health for Washington. And it's been a great forum, really body to prioritize policy for the state and work for the legislature. I really commend our legislative leaders, particularly our chair, Representative Callan, and then other legislative leaders. So I just wanted to highlight that for you all and really emphasize, I think, the criticality of that work. We are venturing in on a strategic plan for children and youth behavioral health. And if you haven't already heard about that or been engaged, I just would welcome you connecting with our team and our contractors who we've been, the legislature has funded some of the work to be able to, in philanthropy, Balmer Group and others supporting this work. So good opportunity there coming up here, and I should have information for you And Justin, I might have to just follow up with exactly how to connect into that work if you're interested. I'd highly encourage it though. So Justin, I'll let you know. I'm just sending a note to Diana Cockrell now. Many of you probably know Diana Cockrell, who is helping lead that portion of the strategic plan work. Anything else? I mean, I think just, maybe on topic there, that co-occurring population of behavioral health, and particularly people with intellectual developmental disabilities, especially the transitional age youth, adolescent age, has and will and continues to be a important area where I think the state needs to invest in services, either autism spectrum disorder services, ABA therapy, services for people in crisis and family supports. Our Y services are great. We've got good CLIP services, but sometimes they're oriented on the behavioral health side, not as much on the ASD, the autism spectrum disorder, ABA therapy, or IDD support sides. And I think there's really a gap that we've identified. For example, our CLIP programs really don't accept people today with those sorts of IDD needs. And so we have for some time now trying to build out services. There are Developmental Disabilities Administration building out a small facility, 16-bed facility, to help with that. And we will hopefully see some good success there, but really just developing that now. So it'll be an evolution, I suspect, but so critical.
And Jason, we would be very excited to hear more about that. We have a lot of work that we're doing on our end, and being able to partner with you is on future-oriented thinking on that would be great. Any other questions, thoughts, feelings, expressions of emotion? Hearing none and seeing none. Jason, do you have any other?
I don't, but Jessica, I think you had a couple of points. Did you want to raise anything else this morning?
I was just wondering if you wanted to give any updates on the Apple Health expansion program, Jason, and I was thinking I could give a couple of seconds. Let me see. There we go. I could give an update on our 1915I work, which is a new state plan authority that we recently received. Some of you who have been around for a little bit, this new authority is going to replace what we called Medicaid personal care back in the day. And it's a one-on-one supportive, it's not a clinical service, but it's a home and community-based service where folks who are living in residential settings like an assisted living facility or an adult family home can have a one-on-one support that they need due to behaviors related to their mental health diagnosis. It right now is specific to mental health, and there's one TBI diagnosis code as well for now. But this will allow folks who are discharging from higher levels of care, hopefully to have the resources and supports that they need in the community to stay in the community safely. So that's one new program that we're working on. We're doing it as sort of a phased in approach. As I mentioned, we had that Medicaid personal care. It's transitioned to behavioral health personal care. It's so over the course of the next year, as those folks come up for a renewal of their care assessment, then we'll be transitioning them over to our new program, which will allow us to draw down Medicaid Medicaid dollars to support them. So that is sort of that work is starting July 1st, and we're sort of in the whole implementation phase of that effort.
I know, Jess, you have to hop off, and I'm happy to stay on and cover anything else. Any questions though for Jess on our 1959 work? Or Jess, remind me, what are we calling it now? I always get it wrong. I still call it behavioral health personal care, but behavioral health supervision.
Supportive supervision.
Supported supervision
is the service, and it's under a community behavioral health support services state plan.
Pretty critical service for particularly people leaving state hospital and trying to live in community successfully. And so we really do need this, and partner with our long-term care partners at DSHS to offer the long-term care side of the service as well, but which is complex, blending and making sure to coordinate between the two different service levels. So that's sort of our continuing efforts with regard to integrating care here. All right, Jess, thanks for joining. I think you have to hop, don't you? All
yes,
right.
thank you for having me. If folks have questions, feel free to reach out later. Happy to connect one-on-one.
And I'm happy to stay on, Justin. I think might be useful if you have time, if you want me to cover Apple Health expansion. And I did find the how to participate on the children and youth strategic planning. So I added that in the chat if anybody's interested about that. Do you want me to cover Apple Health expansion, or do you need to move on here?
Well, I guess I'd leave it open to the group. We have some individuals that do need to leave. So is there anything specific on the Apple Health expansion that would be impactful?
Maybe 1 minute on this. July 1, the program begins. June 20th, open enrollment begins. Unfortunately, it's a capped program, so there's only a limited amount of money. We expect 13,000 individuals. Sounds like a lot, isn't a lot. We expect to have need upwards of 40,000. We know from the exchange that there's probably 18,000 who are ready to go. So we expect that June 20th, 21st might be the extent of open enrollment, and we may have to turn it off. So it's that sort of urgent, and again, these are for people who are not otherwise qualified. They're very low income, not otherwise qualified for Medicaid or other governmental subsidies. So the state legislature is opening up a Medicaid-like program for immigrant health. So that is the quick rundown. July 1 begins, but really June 20th, and we expect it to have to be turned off due to our cap pretty quickly. Be a tough communication piece for some in the community. So just wanting to raise that awareness with you now. Engaging very heavily with community organizations across the state. And it's, it really is tough. Great opportunity, yet tough to have to deal with caps and how to manage that and how to communicate that properly.
And Jason, for anyone who wants to enroll there, you go through the normal process on Apple Health and apply to there.
Yes. Yeah. Washington Health Plan Finder online for most individuals. If individuals are over 65, you can apply through Washington Connections or go into a DSHS office.
And who qualifies for this service?
Anybody who is otherwise would be qualified for Medicaid, but because of immigration status, they cannot receive Medicaid. And Shannon, that is basically 138% federal poverty level or below. Thanks, Justin. Thank you, everyone. I'll stay on and listen in if you need me. But I think that covers it for HCA today. But
Excellent.
again, if there are other questions that come up, I'll try to be available.
Excellent.
All
Very
right.
much appreciated, Jason. Thank you. All right, move on to our next agenda topics because we do not have our other state entities on the line. We'll just do a quick quarterly update from the ASO, kind of what's going on here that does both impact Spokane and our 6-county region. So I'm going to turn it over to Ashley McGee, our Integrated Behavioral Health Manager with the ASO, and Jessica Thompson, Program Administrator with the ASO, to give a quick update on opiate dollars, some regional behavioral projects, and an update on our crisis line and 90-day integration, which of course, Kelly, on that topic, you can also jump in anytime you'd like as well. So Ashley, take it away.
Yes, hello everyone and good afternoon. Felt it important to be here today to share on these updates. So as Justin indicated, I'm the Integrated Behavioral Healthcare Manager here at the ASO, and we have been busy at work on various different avenues. One of the first avenues we will be talking about today is the Regional Opioid Settlement Fund Project and OAC date. The Spokane County Community Services Department, under the direction of the Board of County Commission in collaboration with them, have been working on developing priorities for opioid settlement funds. And I believe that has been shared on in the past in this avenue or in this setting of the work that has gone into that, such as a survey that went out to all Spokane County residents to be able to open to Spokane County residents to complete, and a panel to review those results and
Well, it looks like we lost her, so I'll just give that update until she gets back on. So Spokane County had, for the last 10 months, been working on various projects to get opioid dollars that we received as part of settlement out into the community, as part of the feedback from the community, as well as feedback from professionals and officials in our county region. We, Spokane County Commissioners, approved $7.2 million of opioid dollars to go out in the community, which includes various investments in our regional crisis stabilization center expansion, which will provide for a crisis relief center and sobering center co-located with medical alongside that facility. Now that's going to take some time to build out, but as part of that project, we are looking at one of the first relief centers for 24/7 response, and individuals who are provided services there would be available to all the 6 counties. We do understand transportation, our challenges do exist as part of that, but we do want to make sure that the availability of relief center, not only to address the opiate crisis, but all substance use challenges experienced in the field are available as soon as possible and regardless of the need that exists. So drop off as well as walk-in would be provided. 90% of those referrals would have to be accepted. So that's one thing we're working on. We have a federal earmark going out as well as a state request. So there's a lot of work on this project. But as I said, this is going to take a couple of years to build out. So as part of that, the commissioners also approved an immediate investment of a triage and sobering dollars to provide for services right now. And so that RFP will be closing on the 18th. It'll be 1.2 million going out to a facility to renovate, improve, and or to initiate operations for services for triage for individuals encountered in the field by law enforcement or first responders to allow for immediate stabilization and referral into treatment. So that's something that will be closing. We hope to address facility here. Again, really looking at that key connection in the community. Then 2 other ones is an expansion of both our analytics and data review in the community, looking at how individuals with both substance use and opioid use disorder are being engaged by first responders, health, communities, as well as our medical centers, collecting that and doing a better job at understanding in all those points, do we have a definable definition about what those intersection points look like? What are the substances and how frequently do those interactions occur if they don't result in an overdose and or death? Because those are ones we are tracking, but what about the ones that we are not, in terms of the individual being or administered Narcan and they were successfully diverted, at least medically, into the system and prevented from an overdose and subsequent and potential death. So those are things that we're looking at building out with our sheriff's department. So commissioners approved dollars for that. And then also an expansion of housing support for individuals experiencing NAS and mothers and families who have babies, both with substance use disorder and the babies born with either NAS or some substance use involvement. This would allow for expanded housing support in a co-located safe location so that as part of the transition from NAS treatment, they continue to have a supportive milieu so that they're not returned back to a potentially unsafe environment where that continuation of trauma, challenges, and substance use involvement may occur. So those are areas that we're looking to expand out in Spokane County. See, we have a hand, Commissioner Rosecrans.
Thanks. Can you talk a little bit more about the analytics piece of that and whether that analytics, the scope of that work will include a real examination of the cost benefits of this program and the level of effectiveness that taxpayers are getting on their expenditures?
Specific to that program or in total of all of the various investments?
Well, I mean, that's always a question on my mind is these programs, theoretically, they sound both important and well constructed. And then the sort of the bottom line report, it doesn't seem to be as robust as the initial framing of the issue. So, I mean, you can speak to either of those. It's sort of a continuing theme in my mind. I'll let you decide how widely to expand your answer.
Excellent. Yeah, and that's an absolutely critical point as we look at the investments that we're making. And it's one that the commissioners wanted to bake into all the investments. So as part of our review process, not only do we say, should we do this, because that's what the community is saying, but is it the best and necessary service, not only to benefit the residents of the region, but also to achieve the end goal, which is to actually resolve or reduce some of the unnecessary hospitalizations and impact that the community is feeling. So that's what we took a look from. And so all of these investments are either areas that are not well funded, or there's gaps, or there's challenges on how those services are applied currently. And so because right now we don't have a place that we can drop individuals off within 24 hours for sobering and or triage other than the ER. And they're taking up beds that are exponentially more expensive and taking up resources. So part of the benefit, or I guess the analytics we would see, is reduction of unnecessary hospitalizations or crisis system involvement or law enforcement involvement. So we are tracking those numbers as part of the investment dollars being put in. I think the second aspect is how are the dollars being spent in conjunction with other fund sources. So as part of the build out, we are looking at partnering with other organizations. So ongoing, as we look at crisis relief, we're working with HCA and our MCO partners to say, what does that billing and funding look like? So when an individual who is covered, once we have those rules in place, how are we being able to partner and access Medicaid at the same time, which would then hopefully get them into longer and more comprehensive care, so we see better outcomes down the road. So that is also something we're working on and we'll be tracking as part of service delivery. The part that we talked about, the law enforcement getting the data analytics expansion, that has to do more with understanding what is the actual need in the community so we can better respond to trends that are occurring. One thing we realized is definitions across different areas were being utilized, but not all coinciding or really falling in line in a universal sense. For example, our medical examiner looks at overdoses that result in death because that's their job. And they look at what is the primary cause of death. Well, what about other substance use or other involvement? Our medical facilities, as well as the hospitals, look at individuals coming in for overdose and involvement. So they may be diverted. So we see those, But what about the ones in the field that were diverted at the time that law enforcement engaged or a community member did, and they never received medical care follow-up? All of those have different definitions, but not all are collecting the data in a more cohesive sense. So part of this was to say, is law enforcement's involvement, what are you seeing? What are the trends? What are the primary impact in the community that's occurring? And then collecting that data to the regional health district as part of the hospital, medical communities, and behavioral health providers, and then giving a better picture of the impact. So I think two areas that we're looking at is better idea of the trends so we can better respond effectively to our investments. But then in a greater sense, if we're investing in all of these areas, how well are we looking at the money being spent? And is it impacting the way that we intended it to be impactful? Meaning, we know that there's people that may or may not continue to use substances and get involved, but are we seeing a reduction of that involvement downtown? Are we seeing a reduction of unnecessary engagements, both in the crisis system and hospital system? So we actually see shorter wait times at the ER for people with medical conditions. And are we also seeing better care and more comprehensive services when we look at individuals who have less recidivism in carceral settings or with law enforcement directly in the field? You know, instead of 6 times going out to the person who may be having involvement with businesses downtown, they only have 2 because we're able to divert them into other services. And I look at this as a comprehensive engagement because these are not the only investments. We're also looking at investing in co-response, expanding resources for fire and law enforcement so that they could better be equipped and not take up additional resources. So taxpayers spend less on sending a full engine out. You know, we have $1 million engine blaring their lights. You have a whole system offline. We only will send a 2-member team out with law enforcement so that there's a better, more effective response with less cost. So I think those are all areas we're looking to expand, and we will be tracking. But this is new. This is something that we're piloting in terms of how we want to approach the community, and it will take time to build it out. So to your question there, Commissioner Rosecrans, I think it's a critical aspect. I think our intentionality is to ensure that all that information is available and taxpayers are aware of how their funds are being spent. But I'll be frank with you, we are hoping that it does, and we'll continue to evaluate to make sure that occurs. But we know best case scenario is the cost may still be great, but even a 5% reduction of the hospital is beneficial to residents. So I guess that's how we're going to have to determine how that's being spent, is what do we want to see as a community? And I think that's a larger conversation. So I hope I answered that question.
That was both well reasoned and well articulated and spoke to a central concern that I have is, well, 2 concerns. One is that the lack of coordination that what you just articulated is intended to address. That's great. Coordination is hard among siloed governmental entities and private entities. And the second, that this resource-rich and a revenue-rich environment that we've been operating in for quite a while is always subject to change. And having steps taken that anticipate that change in the most effective way before it reaches crisis mode is good. So everything that I've heard in the last 5 minutes, I applaud and hope that it leads to meaningful improvement. So well done.
And I appreciate that. Part of the lessons learned that we did Spokane County with the SRSC was realizing that conversations about sustainable funding need to be concurrent with discussions about capital investment. And that's what we're doing. So part of a long-term strategy is, I don't want to build this for 1 year. What does it look like 5, 10 years down the road? So looking at, is it beneficial to the community, but more importantly, can I ensure that that funding will remain? And that's where we say our conversations with our the HCA and our state entities, as well as our MCO partners, really is critical. And we're also looking at commercial insurance, ensuring that, you know, for the 20 to 30% of our population that may need the services and are commercially insured, that they are also part of the conversation. So I appreciate that. And it is something that we are constantly discussing, at least. I don't know to what extent I can give assurances, but certainly it is at the forefront of our planning and forward thinking. That's just a quick overview. I know I touched on a bunch of topics there. Another thing we're looking at doing is our co-response, partnering with City of Spokane and City of Spokane Valley Fire. These are ones that we're hoping to build out. Now, in our 6 county regions, there will be additional look at investment for crisis response investment, but that's where we do a give and take, right? The moment we invest in expanded crisis services, then we're saying hire more people. It takes away from the current staffing for your outpatient services. So we always want to be mindful that if we build out in one area, do it smartly and in a timed approach so that we don't overwhelm a community with saying transition everyone in your outpatient over to crisis. That doesn't work because then we have no one to go in to cover services for long-term care. So we're looking at long-term and strategic planning for our crisis system. It is coming, and we're working directly with our healthcare authority partners because as part of the mobile rapid response and 988 expansion for the crisis system redesign, we're trying to be mindful of how this looks over a period of time, as well as in alignment with what the state has intended for service delivery. So bear with us on that. More to come, but I do envision we'll be having a lot more conversations in the coming months with our regional and frontier rural communities as to how that will look for them as we invest. But our current commitment has not changed. If anything, we're looking at better and more responsive care in the years to come. And then for our regional crisis line and 988 integration, as I've discussed on numerous occasions, we are looking to really have one entry point into the system for the community so that there's less confusion. That's the goal intent of 988 for individuals who need crisis response and they are currently experiencing suicidal ideation. 988 provides an easy access, a uniform messaging to the community, and then also allows for a central and co-located response. That's the intent and purpose. Now, for our region, we also have a really robust regional crisis line. We're looking at saying, how can we best integrate those services so that the community has one singular line, but our service for the providers who are making referrals still allows for direct access to our crisis system. And so we are working on doing a revamp so that we have a central located mobile dispatch and response team that is both vertically integrated with our 988 provider, and that's Frontier Behavioral Health. So again, we're very, very lucky to have them. They're also partnered with all of our frontier rural communities and our rural crisis providers. So that partnership, that ongoing collaboration will continue. And in fact, that's the intent and purposes, even if they call 988, that Frontier's existing relationships with our regional crisis providers would be able to be leveraged and utilized so that regardless of the line that individuals call, services are being directed without interruption. So bear with us on that. That has been years in the making, and we have a great plan. I think we have one of the best plans in the state for how that will occur, but it does take time so that the community really truly sees no interruption to how they're receiving it. And so more to come on that. Kelly, I don't know if you have any input you want to provide on that, but really just an assurance to our communities. Singularly, our goal is no disruption to any of the services or to the community members needing that help.
Hey, Justin, I'm having really unstable internet.
Sorry, Kelly, I think we lost you there. Yeah, Kelly, if you are talking, we cannot hear you, or I cannot.
Oh, Justin, can you hear me now?
Yep, we got you now.
I am having really unstable internet. I think Jason McGill and I are on the same plan, same carrier.
Ha.
No, I don't have a lot to add, but just thank you for recognizing that we have been working on this for some time now because of our commitment and the ASO's commitment to ensure no disruption, as minimal disruption as possible to our community, but to our partners as well. I think we have a great plan because we are looking through the lens of how to make things efficient through a transition and for a long-term plan. But I think our biggest opportunity here is to really streamline a referral process for our community partners, whether it's a referral to a DCR for an ITA evaluation or to a mobile crisis response team, to whatever that might look like. Lots of opportunities to allow our providers to make direct referrals and allow for us to respond quickly to get the services out to the community. And I think that's just really important to echo. I know you did a nice job saying that, but the commitment from and the support from the ASO to align with us on our whole intent is just really appreciated.
Thank you, Kelly. And yes, more to come, but don't expect any change as it stands now. The RCL is still available and staff for anyone calling those. You know, community members are like, no, go get rid of it. The intent is not to get rid of that. We'll still see this same service, but right now we've got two essential services running concurrently, which is our RCL at 988, and they're all staffed through FBA. So looking at better usage of resources to better serve our community is really the heart of this, and making sure that we're responsive. All right, so enough of Justin talking. That's our updates. I'm going to open it up to any of our community stakeholders and community members here on the line, or any of our elected officials. Any questions, thoughts, or other things that you'd like to mention? All right, well, hearing none and seeing none in the chat, and recognizing this is Friday morning, and thankfully it's not 4:30 on Friday evening. So hopefully this works better with everyone's schedule. We will be convening again in the September period. And again, we are sticking with our regularly scheduled Fridays on the third Friday or second Friday of the month of the quarter. But we'll be continuing on the morning schedule to better accommodate various individuals' time, so we don't send you home late on Friday evening. If you have any questions or have any other feedback you'd like to provide, let us know. We'll send out the information, if any, provided by our state entities. And I just want to say thank you, Jason and team, for sharing today and for the questions on investment, as well as our providers that have joined us today. Have a wonderful weekend. Get out in the sun and just enjoy things. We look forward to seeing you all later.
Take care.
Thanks,
Thanks,
Justin.
Justin. Bye-bye.
Take care. Bye.
Well done. Thank you.